And then you might get me a stereo, actually. Stand too close. Hello. It's lovely to see you all today, and I'm very pleased to be here. It feels very strange to be talking about having a conversation when there are two of us and, I don't know, 70 of you or something. And we are going to ask you a little bit later on to have a quick conversation with your neighbour, so perhaps we should just start off by saying hello, if you haven't already said hello to the person next to you. Okay, that's more than hello. It's fatal to suggest that people actually start talking, isn't it? That's a mistake. And it's helpful, I think, to everybody to actually get started, to get the voice in the room. And I know I'm standing here thinking, oh, this is a little bit scary. There's the two of us, and there's a lot of you, and you're as expert as I am in having conversations. I'm sure you have just as many as I do every day of your life. However, what I'm hoping that we can do today is run you through a little bit about our context, so why we're here, what gets in the way of communicating with each other, give you a framework, so things to think about when you're going into a conversation that perhaps feels as if it's going to be a bit tricky, a bit difficult, and how we can oil the wheels of those conversations. So does that sound like something that you're signed up to for the next kind of 40 minutes? Fantastic. So, you were going to talk about affinity.
I'd just like to tell you a little bit about affinity, because that's the context in which we are really here today. As Barbara mentioned earlier, Affinity is a voluntary community group. It was established a couple of years ago in the area of Prestwood and Great Missenden in Bucks, with the aim of supporting and encouraging local individuals to talk about end-of-life issues, hoping that they just might have conversations around the kitchen table with their families and feel more at home doing that, which is not a very British thing to do. In response to our initial workshop, when we asked the community what they thought might be helpful, we developed a series of workshops that distilled some of their thoughts into practical issues that we felt we could address. And one of those issues was called Talking About Dying and Death. And we have subsequently run it as a pilot study of workshops. We've also run it for the Anglican Deanery Pastoral Care Group in Wendover. And it's the basis of the work that we're bringing to you today. We would like to share it with you. And first of all, I'd like to start with a little story. People find these conversations really quite difficult because there are so many barriers. And a community palliative care nurse once told me that she was visiting a patient at home, just a routine check-up call, and she knocked on the front door, which was opened by the two adult children who were there caring for their mother, who was approaching the end of her life. So the door was opened, the children answered, and they said, "Oh, lovely to see you, please do come in, but please don't tell Mum how ill she is. We really just don't want her to be too upset." And so the palliative care nurse acknowledged, I don't think she said yes, but she acknowledged what they'd said, and they showed her to the mum, who was in her bedroom. And then the children left the nurse with the patient so that she could get on with what she'd come to do. And the patient said, "Oh, it's so lovely to see you. Just shut the door, would you? Oh, thank you. Please, before we begin, can I just make sure, don't tell my children how unwell I am, because I really don't want them to be upset." Now, I know that you've all probably had similar experiences. I think it demonstrates our fear of upsetting, fear of being upset, fear of introducing a situation that we might not know how to handle. Scared that we might not be able to cope. And so the community palliative care nurse did her clinical bit, but during that visit she also got the family to speak and communicate honestly with each other, because she felt she couldn't just ignore what she'd heard. She helped to remove their fear so that as a family unit they could then communicate honestly with each other. That's an enormous thing to be able to do and to facilitate and help and improve the quality of care that follows, because people are being honest about their fears and their hopes. So if we as carers in the social care or healthcare professions, if we can deal with our fears about talking about the end of life, then we can engage better with patients as they deal with theirs. And I think that's a really important thing to remember.
Thank you. So the first thing we thought we would look at are actually the barriers. And clearly this is just an example. You might have a patient who may have some of these thoughts going through his or her head. White coat syndrome, figures of authority, scared about what might or might not be said, and projecting other things that have nothing to do with the situation at all. You know, it's just like my stepmum. Well, you know, you might love your stepmum, or you might have that feeling that it's straight out of a fairy tale and one of the evil stepmothers. Nothing to do with the conversation, but we all project stuff on other people. So that kind of noise might be in a patient's head. Their own version certainly will be. In the professional's head, hate breaking back news, do too much of it, difficult experiences in the past, scared of reactions. What do I do if somebody gets really angry, really upset? I've got 10 minutes and I've got a huge amount to try and get across in those 10 minutes. How can I possibly do that? And in all of that, it's fear, all sorts of assumptions and previous experiences that are getting in the way before you've even met the person that you're trying to talk to. So the first message was actually, if we can try and change the tapes in our own heads before we start, it can make life easier. You actually can't do anything about the person you're talking to. You might hope that they would be coming into a discussion with trust, wanting knowledge, and recognising that you're you, not somebody else. You don't know that. You can control, to an extent, your own thoughts about the conversation you're embarking on. You know that you are an experienced professional. You know that you're not actually alone, although I bet it sometimes feels as if you are. And what a fabulous gift for someone to have your undivided attention, maybe for a short period, but actually if that's your sole focus, that can be quite special. So, that's perhaps, before we start, thinking through what's about. The struggling to turn the pages over here. There we go. I do quite a lot of work in transactional analysis, and the father of TA is a chap called Eric Byrne. His recommendation was that people planned for, in his case, therapy sessions. Plan everything. And then 5 minutes before you start, forget it all. Approach the conversation like a newborn babe, I think was his phrase, on the basis of actually trying to clear out any of your assumptions and being in the conversation, in the moment. And I sometimes think that's a lovely way of approaching it. You've done your preparation, you've done your thinking, trust that, and then be present. So that was barriers before we start. If I move us on then into looking at a framework. So as I said before, we all have conversations hundreds of times a day. Some of them are very straightforward and very easy. Some of them are very difficult. And we've developed this as a framework for thinking around the conversation when it is difficult. First off, what is the context within which you're talking? What is the content that you and the person you're speaking with may need to share? And what is the process of the conversation itself? And what's the contract, what's the deal you're making with the person about the conversation? So I'll look at each of those in turn. You will know something of the context before you start. You may not know all of it. You may be talking to somebody who is dealing with a serious illness. You may be talking to someone who's deteriorating. You may be talking to members of their family. You may be talking to more than one person. You may be talking to the patient themselves and a member of their family. There may be other factors going on for them in their lives that would be helpful to know, but getting a view as the context within which the conversation is taking place is perhaps the first bit of background to place your conversation in. Content is really, I guess, the thing that we tend all to start with. We know that we have some facts. Now, they're there as observable facts, but they may be, you may be hanging on to a diagnosis in your hands that you wish to share. There may be things that are completely neutral, kind of, people are aging, you are now 80. Your parents are aging and need concern. There may be practical issues that you raise, the person you're speaking with raises. There may be nothing that you can help with, but hearing it, having it on the table, signposting, suggesting they pick it up with someone else if it's not something you can deal with, all indicates that they're being heard. The feelings I think of as part of the content, because it tells you, if people share, it tells you how serious they are about something. Is this a huge shock, in which case they've got stuff to deal with, or is this stuff that actually they kind of knew anyway and you're kind of confirming things? Mutual understanding obviously helps. Support, understanding that you hear their feelings as well as the words, all allows for the richness of the conversation to move things forward a little bit. I think you had something to add here.
So I was talking to a colleague last week who's got well over 30 years experience as a general practitioner. And he told me, after all these years, I still find it very difficult to initiate these conversations. And I'm sure some of us echo those feelings. So I thought it might be helpful to give a few pointers in this section of content, how to get started. And these questions are ones that you may well want to put into your own words and just use as and when you feel they might be helpful. But using open questions such as, what's the main thing on your mind? What's your understanding of your health can be very helpful, because that allows the individual to actually vocalise what's happening to them. And sometimes that's the first time they've really thought about it, and it can actually be seen by them as a real issue. What are your fears and your worries for the future? Somebody may say, I haven't got any, but that would be surprising. It's a very open and gentle way to approach these discussions about end of life. What matters most to you? That's really what we all want to know, because then we can plan accordingly. Even though we can't dictate exactly how their future care goes, we can do our best to plan for it. And what are your priorities? They may surprise you. They might be very simple, they might be very complex, but we won't know unless we ask, and everybody is different. So using your own words to frame that sort of question in a very open and non-threatening way can be a helpful way to actually get started if you feel you're in a position to do that.
One of the things that I find is often overlooked in a conversation is what I've termed process. So the things that are perhaps going on in the background and aren't articulated, but can make a huge difference. So the first off is it actually safe enough to have this conversation? And it might be something to do with the timing, the place, the people that are present. It might be something to do with where you are yourself. If I am trying to have a conversation with someone around the end of life and my mother died 2 weeks ago, that's going to be much tougher than if it's any other Tuesday. Am I the right person to have the conversation, therefore? If I'm stuck with it, maybe I can make it safer for myself and the person I'm talking to by actually saying, I'm having a tough time at the moment because I'm dealing with stuff, so please forgive me if this doesn't come over quite as you might expect. Because then it's in the room and people know, rather than making all sorts of assumptions about the fact that, well, maybe you don't care, that sounded a bit cold. In fact, you're trying to protect yourself. So, is it safe enough? Is it safe enough for you? Is it safe enough for them? What are their frames of reference? Are there cultural and family givens that we don't talk about things in this family? Or actually, if it's anything medical, we always want niece to come along too because she's got some medical training? Or are there very approaches that we're not saying anything here? Being present is back to perhaps trying to approach like a newborn babe, being open to creating the conversation between you. It's not one way, I quite like the phrase, it's being co-created. It's between two or more people. And therefore being absolutely focused for the time you have on listening, hearing, responding, as well as saying your piece, can make a very big difference. Clearly, if in the back of your mind is the fact that actually you need to go and collect your child from school in 10 minutes and can we get this over, it gets in the way. So being absolutely present and thinking through then the process of the conversation can facilitate the content. And my favourite piece in thinking about all of it is actually what's the deal about the conversation. What are we going to talk about here between the 2 or 3 of us? Why does it matter? Who are we for each other? You may never have met this person before. They may be somebody you've been caring for over many years. You may have more than one hat. You may be their daughter and a qualified nurse. It'll load expectations. So actually being clear about what your role is and what their role is in the conversation, which hat you're wearing, why you're there, what your needs, what do you need out of the conversation? I desperately need this piece of paper to be signed. What are their needs? Well, I need information, I don't need information. I need you to hear that I'm really scared. I want to keep that to myself. Who needs what? And so, right up front, actually, what's the deal about this conversation can really then help make it safe enough to progress. And I think you had a nice story about that one.
I'd like to tell you about Philip. He's a 78-year-old resident of the nursing home that I look after with the practice. And he is there because he is having palliative care. He has got cancer of the colon, which has metastasised to both his lungs and liver. And I first met him a couple of weeks ago after I'd been on holiday for a couple of weeks, so he'd arrived while I wasn't there. So I didn't really need to do the original clerking in, but when I went to visit him it was very much so that I could introduce myself as his GP, find out if he was comfortable and if he had any particular issues he wanted to talk about on that day. So we were drawing towards what I thought was the end of our conversation. We talked about his symptoms, how we would manage them, things like that, and how he was settling in at the nursing home. And then he came out with, "So how long is this business going to last for then, Doc?" That was a gift. Yes, maybe I felt, right, got to think on the spot here. But it was a huge gift from him. It was permission from him so that we could talk openly and honestly about his future, about what to expect, about his fears, his hopes and his wishes. And that was the first time he'd done that since he arrived at the care home. This week, I met with his daughter before I saw him, and I talked with her about her concerns and her hopes. And then I went on to see him with his daughter. And this will continue. Our conversation is developing over time. Our rapport is increasing, and it's a conversation with him and people who are close to him. And I feel that that amazing permission he gave me was, in a way, part of the contract. It showed that he was willing to engage. And it also shows how we can use time as a tool, as we so often do, and develop our conversations. It doesn't all have to happen in 10 minutes. Particularly in primary care, we have that luxury of being able to revisit, and I know it's harder in a hospital situation.
I think that's the point. I've talked about this as being a conversation. Clearly, there are occasions when there is a one-off conversation on this topic. Very often, though, it's part of a whole series. It builds, it grows, as trust develops, as it becomes safe enough. And the intention of sharing this model with you was really to say, yes, it is just another conversation. Here are some, I almost think of them as coat hangers, really. You know, you can kind of think about them and, yeah, okay, that fits there, and is there anything I've missed? A framework that might help. Because if we can have open and honest communication with those people who are willing to engage, it makes a phenomenal difference to them, to their loved ones, and that's kind of the name of the game. The last piece that of kind of this sort of chalk and talk we wanted to talk about was something that just, it's a little bit of fun perhaps, but can oil the wheels of conversations. Professor Robin Dunbar wrote a lovely book some years ago called From Grooming to Gossip, and he was pointing out that apes groom each other in order to demonstrate their affection and closeness to each other, and that we as humans have developed the art of conversation, and actually that's how we tend to be close to another person, is to communicate with them, to chat, to talk. And how important, therefore, it was that as part of our conversation we stroked each other, hence stroking the individual. And I've used these playing cards as a way of demonstrating what I mean. A heart, you're stroking someone for being who they are. How lovely to see you today. Well, I feel quite good for turning up. You're so stupid. It's a bit of a club. It's labelling me. I'm sure many of you have had children, and it's, you know, don't tell the child off for who they are, tell them off for what they're doing. So the conditional, you know, kind of, be really nice if you could actually manage to take your medication on time for a change. It's perhaps a bit of a backhanded, so a spade, you know, please get it right, you're not yet. Or how lovely it is that you are managing to walk up the stairs still, that's lovely. And these sorts of comments at an opening, at a closing, in the middle of the conversation, if it fits, allows the person to feel seen for who they are as an individual. It's me you're talking to, as opposed to any other nameless person. And interesting how research has shown that actually even the club benefits people than being ignored. It's that no, faceless, I'm just a number, that is soul-destroying to all of us. So I think it's a little bit of fun to think about how one might stroke the person, but it's also a way of focusing on them as an individual, and that again really helps any conversation because I'm talking to you, not anybody.
Thank you, Pippa. I just want to finish with another story. So this is about Norma and Bill, patients of mine who are both in their 80s, who I've known for a long time. They're quite frail. Norma has got osteoarthritis that really limits her mobility, and Bill has got Parkinson's disease, which is progressing slowly. They live together and they look after each other very well. And they came to see me the other week for routine review. It was Norma's medication review. And I knew that I should start the process of advanced care planning with both of these people because, well, they fit my 1%, and I should start, but how do I do it? And because it was just a medication review and there wasn't much else going on, I had a bit of time, so I thought, right, I shall have a go. So I just bit the bullet and I said, have you ever thought about what care you would want if you were to become more unwell? And my goodness me, the response I got was incredible. Norma said, oh yes, yes, we've both talked about that and neither of us ever want to be resuscitated. And that was the beginning of the conversation. And it was simply brilliant. So by the end of my 10 minutes, I had a very clear idea about their wishes. We hadn't covered everything by any means, but it was a start. And we both knew that we could openly communicate and trust each other and have this conversation. So I just want to encourage you all to push on a door, and you may find that it swings absolutely right open and allows you to have really rich conversations. Take opportunities as they arise. In primary care, the majority of patients who you start this with will want to continue the conversation. Maybe not straight away, but at a future time. You are all really skilled communicators. You've been trained, you've got lots of experience. So use the skills you already have, use your own words with people that you work with, and have a go. And remember that most patients at some point would really like to talk about death and dying, but they might not know how to start. And maybe they're not always ready, but you won't know if you don't ask. So we've talked a lot about communications and having conversations this afternoon. We've got a little bit of time, so I'd love to invite you to turn to your neighbour and just invite you to have a brief conversation and maybe identify 2 or 3 things that you might take away from this afternoon that you think could make a difference in your practice, just for a couple of minutes. Thank you.